Hello and namaste to all of you. This is Name-Shalu Singh from Department of Physiotherapy and Diagnostics from Jayoti Vidyapeeth Women's University. So today I'll be discussing with you about pleural fluid. Now, what is basically pleural fluid? It is pleural fluid basically serves as a physiological function and respiration, and while also being useful to measure and diagnose, assess disease, trauma, and other abnormalities. And a pleural fluid is basically a serous fluid produced by a serous membrane covering the normal pleurae, and most fluid is produced by the exudation in parietal circulation or intercostal arteries via bulk flow and reabsorbed by the lymphatic system. So, thus, pleural fluid is produced and reabsorbed continuously, and the composition and volume is regulated by mesothelial cells in the pleura. And a normal 70 kg human, a few milliliters of pleural fluid is always present within the interpleural space, and the large quantities of fluid can accumulate in pleural space only when the rate of production exceeds the rate of reabsorption. And normally, the rate of reabsorption increases as physiological response to accumulating fluid. And when the reabsorption rate increases up to 40 centimeters, the normal rate before significant amount of fluid accumulate within a pleural space. So, thus, a profound increase in production of pleural fluid or some blocking or the reabsorbing lymphatic system is required for fluid to accumulate in the pleural space. Now, the circulation of pleural fluid. So, the hydrostatic equilibrium model, a viscous flow model, and a circulatory equilibrium model. These are the three hypothesized models of circulation of pleural fluid. And according to the viscous flow model, the intrapleural pressure gradient, it drives the downward viscous flow of pleural fluid along flat surfaces of ribs, and the capillary equilibrium model states the high negative and pleural pressure, and it leads to basal to apical gradient at mediastinal pleural space, leading to a fluid flow directed up to the apex and held by the beating heart and ventilation in lungs, and thus the recirculation of fluid occurs. And finally, there is a transverse flow from margins to the flat portion of ribs and completes the fluid circulation. And absorption occurs into lymphatic system at the level of diaphragmatic pleura. And now this pleural fluid gives a point of reference in assessing the cause of abnormal pleural collection and pleural effusions. So the light criteria is useful way to differentiate between transudate and exudate, so which can then be further evaluated with lab tests and in context with the clinical presentation of the patient. Now, the evaluation of pleural fluid can be used to determine the cause of pleural fluid and help guide the treatment of underlying cause. Now, the concerned issues with pleural fluid. So, there are many conditions that can cause problems with the pleural cavity and the pleural fluid. The following can be the some of the causes, such as a pleurisy, which is pleura inflammation, just causing sharp pain with breathing, and most common caused by viral infection. Secondly, a pleural effusion, which is excess fluid in the pleural space and commonly from congestive heart failure or malignancy. And next is your pneumothorax, which is a buildup of air or gas in your pleural space and commonly from acute lung injury, trauma, or chronic disease such as chronic obstructive pulmonary disease or tuberculosis. Your hemothorax, which is a buildup of blood in pleural space and commonly from injury or trauma to the chest. So, in adults, congestive heart failure and liver cirrhosis are the most common causes of transudative pleural effusions, and pneumonia, malignant pleural disease, pulmonary embolism, and GIT disease accounts for almost all the exudative pleural effusions. And in children, congenital heart disease, pneumonia, and malignancy are the most common causes of pleural effusion. Now, the composition of normal pleural fluid consists of total white blood cell counts of 1.716 into 10 to the power 3 cells ml per ml. So, differential cell count 75% macrophages, 23% lymphocytes, and marginally present mesothelial cells, 1% to 2%. So 1% neutrophils and eosinophils are not present. So of note that there is a slight increase in percent of neutrophils found in smokers and over non-smokers. So pleural fluid is continuously produced by the parietal circulation in the way of a bulk flow, while it is also continuously reabsorbed by the lymphatic system via the stomata in the parietal pleura. And in healthy human, the pleural sac, it contains a small amount of fluid of about 10 to 20 ml with a low protein concentration, less than 1.5 grams per dl, and pleural fluid is filtered at the parietal pleural level from systemic microvessels to the extrapleural interstitium and into the pleural space down a pressure gradient. So the lymphatics open as a stromata directly into the surface of your parietal pleura and provide most about 75% of the drainage of pleural cavity, while absorption through the visceral pleura is negligible. Now, visceral pleura, it does not account for any significant pleural fluid drainage under normal conditions. So, the rate of reabsorption can increase as physiological response to accumulating pleural fluid or other fluids in pleural space. So, the rate of absorption can increase roughly 40 times the reference rate and before excess fluids begin to accumulate in your pleural space. Now, significant fluid accumulation in pleural cavity usually indicates excess production of pleural fluid and lymphatic blockage or some other source of fluid, such as bleeding. Now, pleural fluid is contained in your pleural cavity, which is the space between internal thoracic wall and lungs. So, pleural cavity is lined by fibrous mesothelial membrane that is made up of parietal and visceral layers, and the parietal layer is the lining of internal thoracic cavity, and the visceral layers covers the outside of the lungs. So these layers are continuous and meet to form a double layer at the hilum of each lung, with no communication between right and left pleural cavities. Now, the innervation of pleural cavity can be divided between two pleural layers, and the visceral pleura is innervated by autonomic fibers and is generally insensitive to irritation and inflammation. So, however, the parietal layer is innervated by somatic fibers and highly sensitive. So the parietal innervation can be divided into four sections that have distinct and clinically significant presentations in setting of physiological insults. So number one is will be your cervical, second will be your costal, and third your mediastinal, and fourth is your peripheral pleural zones. So the cervical pleura is innervated by the first thoracic spinal nerve, and irritated may be refer to pain to the inner aspect of the upper limb, and the costal pleura is innervated by overlying which runs down the fibrous pericardium and may refer pain to the ipsilateral shoulder in distribution of C4 dermatome, and peripheral diagrammatic pleural by innervated by lower six thoracic nerves and may refer pain to the anterior abdominal wall. Now, the intercostal, internal, thoracic, and musculophrenic arteries they provide blood supply to the parietal pleura, and the intercostal veins they provide venous drainage to the parietal pleura. Now, the lymphatics of parietal pleura drain into the intercostal, parasternal, and diaphragmatic diaphragmatic posterior mediastinal group of nodes, and the blood supply and the venous drainage of visceral pleura comes from bronchial vessels, and the lymphatic drainage going through the hilar lymph nodes. Now, the anatomical protection of pleural cavities in the bony thorax, which leaves these three areas of vulnerability that may be clinically relevant in setting of trauma to lungs and pleura. So, above the medial end of the first rib and between costal zipsy-sternal angle on the right side and below your costovertebral angles. So, pleural fluid enters the pleural space through your systematic capillaries in the parietal pleurae and exits the via parietal pleural stomata and lymphatics. So fluid has a function. This pleural fluid functions as a lubricant to allow the two layers of fluid to glide smoothly past each other during respiration, and the pressure of pleural fluid is subatmospheric, and it maintains negative pressure between lungs and thoracic cavity, so which is necessary for inhalation while also preventing lungs from collapsing. So now this was all about the introduction of your pleural fluid. Now, what is the clinical significance of a pleural fluid and pathophysiology that is related to your pleural fluid? So, pleural fluid, it develops when changes in fluid and solute homeostasis occurs, and the mechanism causing these changes determine whether it will be exudative, high protein content, or transudative, that is low protein content effusion. So exudate is a fluid that leaks around the cells of capillaries and is caused by inflammation, while transudate is the fluid pushed through the capillaries due to high pressure within the capillaries. So an imbalance between hydrostatic and oncostatic pressure within the capillaries causes transudate effusion, and an alternate of local inflammatory factors that participate a pleural fluid accumulation represents an exudative effusion. Now, the accumulation of fluid in pleural space is due to the rate of pleural fluid production exceeding the rate of reabsorption. Now, effusion of exudative type occurs when filtration rate exceeds maximum lymph flow, resulting in an effusion with higher and usual protein content. And exudate forms when protein permeability of systemic capillaries is increased, causing an increase in pleural fluid protein concentration. And exudative protein effusion generally are caused by infections such as pneumonia, malignancy, granulomatous disease such as tuberculosis or coccidioidomyosis or collagen vascular diseases and or any other inflammatory diseases. So an increase in both capillary and mesothelial water permeability, it will lead to hypooncotic fluid or lower protein contact. And if filtration exceeds the maximum lymph reabsorption, then the parietal stromata transudate forms, and transudative pleural effusion occurs in your congestive heart failure, cirrhosis, nephrotic syndrome, and malnutrition. So the last three conditions, they reflect a decrease in colloidal oncotic pressure due to hypoalbuminemia. Now, localized pleural fluid effusion seen from a pulmonary embolism may result from increased capillary permeability due to cytokine and inflammatory mediators released from platelet-rich thrombi. Now, there are various clinical significances of your pleural fluid. So, diagnosis of etiology is essential. So, as the treatment of exudative and transudative etiologies differ significantly, so exudative effusion almost always requires a further investigatory workup, which may include cytopathology studies, biopsies, and even an emergent thoracotomy. So, attempt should be made to determine the etiology of a patient with an exudative effusion. So, conversely, transudative effusions usually do not require treatment, and therapy should be directed towards the underlying heart failure or cirrhosis, and malignant pleural effusion is common and it denotes a poor prognosis. So, dyspnea and unilateral patent large pleural effusions are typical presentations of malignant pleural effusion. CT and ultrasounds can help differentiate between benign and malignant pleural effusions. So management of pleural effusion should be as follows. So first of all, diagnostic and therapeutic, thoracocentric or chest tube drainage. Secondly, to obtain a pleural fluid and serum studies of protein and LDH, that is your lactate dehydrogenase, and if indicated, consider additional pleural fluid studies such as cell count, differential cultures, or triglycerides. So evaluate fluid using light criteria to determine if it is exudative. Now, narrow differential diagnosis based on whether transudative or exudative. So that is all for pleural fluid. So I'll meet you in next lecture more about more on pleural fluids. So until then, if you have any doubts or any queries, you can contact me. And until then, take care and bye bye.